Well, good afternoon. Thank you, Ambrose, for this kind introduction. But one statement before I start to deliver my presentation. There are 70% males here, and I can tell you, women face in the morning a very difficult decision, either high heels or flat shoes. And I was very happy that in doubt I'm for flat shoes because my talk was lost and we rushed back to the hotels and got the presentation. And I want to say thank you to the wonderful woman who managed to get me back to the hotel and deliver my talk. And I also want to thank Jean-Pierre and Akas and Mark and the organizers for inviting me again to this wonderful symposium. So, unfortunately, I missed part of your presentation, and I hope we have a very lively discussion because we keep a step back now, and I keep presenting information on oral slow-release morphine. That's my conflict of interest, and I'm involved with some drug companies related to the production of medication in the field. Well, the always main consideration, if we talk about medication in our field, one is the efficacy, defined by retention and reduced consumption. The other one is safety, spectrum of side effects. Also, another aspect is the low diversion risk, which I will cover in relation to oral slow-release morphine. And I'm quite happy that more and more quality of life research questions are coming in the field. Is this me or it's a problem? Okay, so now we go back. So, the diversification in our field goes from abstinence towards harm reduction, and most of my talk will be related to oral slow-release oral morphine. I will be presenting data on a formulation what keeps the patient nicely over 24 hours, so once daily dosing is possible. I will end with this information, and I very briefly will cover one medication which is also available in Europe and mostly coming from Germany, which is polamidone. As Ambrose pointed out, my country is quite different to the majority of European countries regarding medication available for the treatment of opiate dependence. I briefly might guide you. On this table, you find the individual countries here. The red column is referring to buprenorphine, and there are many generic products already on the field over the last years. The blue column are referring to combination products, Suboxone. The green color is referring to methadone, and the purple one is referring to oral slow-release morphine. And this gives you an impression over the treatment situation 2 years ago in the individual countries, and which is amazing. In no other psychiatric disease we probably would face this heterogeneity in treatment application. We have Spain here with almost only methadone, and we have, for example, Finland here. Finland has the majority of patients is in the combination products of buprenorphine and naloxone. We have France still on the monoproduct, and Austria, the vast majority in the open field has been treated with oral slow-release morphine. And I will actually cover some of the advantages and some of the disadvantages. We also have polamidone, as I pointed out, which is slowly moving into Austria. This gives you the column related to age. These are the population under 20 until 30, 40, and higher than 40. The purple gives you again the oral slow-release morphine. It's a pretty unequal distribution, and to my point of a clinician and running an addiction clinic, this probably needs to be shifted in another direction again. But you see, and what is actually very nice, that polamidone is also coming in. It's coming in from Germany, where it has been registered for a long time, and it has been available over the last years in Austria, and I'm pretty pleased seeing younger people moving on into polamidone. We have a quite long history. I started the clinical trial with oral slow-release morphine probably in the late 90s. And this is just one graph, what I pictured. It's coming from my colleagues from the pain field. They presented, this is Austria, Denmark, and Great Britain over the last years. And my pain colleagues from Austria say, we are really doing good, treating pain that nicely. However, they pick not up the pain treatment. They pick up, since this time, they pick up the oral slow-release morphine, what is considerably higher dosed than the morphine in the pain treatment. So it's always we always need to be very careful how we're using data. I don't know, okay. You saw this quite broad coverage of slow-release morphine, and there is quite an emotional discussion going on. And it used to be some years ago that people said, well, oral slow-release morphine is killing our patients. So we did a mortality study based on the study which will be known to the audience, ESR study, showing that about almost 50% of the patients were dead after a 33-year frame of investigation. This is our paper, which is actually published 2008. We did not do 33 years, but we did an investigation 6 years after maintaining the patients in our outpatients clinic and having them released to general practitioners. There's also a huge heterogeneity, like in France, which is dominated by GPs in the treatment. Also, it's my country, in contrast to Scandinavian countries where it's different. And what did we find? We find 90% of our patients were still alive. Unfortunately, almost 11% were dead, which is, again, a confirmation about the high mortality rate in our opioid-dependent population. This is giving you an information on the standardized mortality rate, considering and correlating for the same age population. One person would have been expected to be dead. Unfortunately, in our population, 29 patients were dead. And you see the indicators who actually had a higher risk of dying were male, unemployed, frequent hospitalization, or opioid maintenance, and socially deprived. This is pretty much a confirmation of what we have been knowing already. But what was the purpose of the study? We looked into the post-mortem forensic analysis, and we saw it's about 1/3 was dying HIV-related, another 1/3 related to somatic reason, another one in relation to other psychotropic medication, and actually one patient only had morphine and one patient only had methadone in the forensic analysis. So this medication, at least in this structured investigation, was not related to an increased mortality. However, what has been pointed out always, that we need to do something in order to deal with the high mortality rate. Just very briefly, these are the pictures 2002 from the EMCCDA. These are the pictures 2007. So you see that about 40–50% coverage of patients in opioid maintenance treatment in the European countries. So there is a lot of patients out there who look for other and additional treatment in this field. It was pointed out by Wim, and it's well known, the Cochrane review stating that methadone and buprenorphine, the preferred medications for the treatment of opiate dependence, with having a slightly better outcome for methadone compared to buprenorphine. But it's also indicated that oral slow-release morphine may be effective, and it's categorized under C. We do have 2 products in my country. And actually, it's not only in Austria, there are some other European countries where this medication is available. And for example, in France, I'm aware that there is a considerable off-label use in using slow-release morphine for the treatment of opiate-dependent patients. We do have 2 different products. One actually is a capsule with small pellets containing oral sustained-release morphine, and the other one is a tablet. Both medications, and there are other studies out in the field. I'm happy to provide this information if you want, about keeping the patient nicely over 24 hours. But the first publication, actually, what made us alert to study and use this medication was Mitchell's publication in 2003 in Drug and Alcohol Dependence, where he actually suggested that oral slow-release morphine might be an alternative for maintenance to patients who are not really very well responding to methadone. And at this time, he looked into 18 methadone-maintained patients, transferred them to oral slow-release morphine, which was an open-label design. And he had a ratio of 1 to about 5 from methadone to oral slow-release morphine. And his results were that SROM was associated with improved social functioning, weight loss, fewer and less troublesome side effects, greater drug liking, reduced heroin craving, enhanced sense of feeling normal. The majority preferred oral slow-release morphine over methadone. But this was only an open label study, only lasting over 4 weeks. We actually published then one comparison study looking into morphine versus oral slow-release morphine in pregnant addicts. And I just give briefly the information because this was not a double-blinded study. This was it was a controlled study, but with open medication. And what we found is that both substances were safe, well-tolerated, both prevented preterm delivery, both were safe, both induced a neonatal abstinence syndrome with no intensity and duration of neonatal abstinence syndrome. But we found a significant lower concomitant consumption of heroin and benzodiazepine in the oral slow-release morphine group. There were limitations, and this study, as you see, has been published already in 1999. So there was a different structure in how to treat the neonatal abstinence syndrome, for example. I hope nobody actually would use any more phenylbarbiturates for the treatment nowadays. And then actually, we started I think a considerable nice evidence-based clinical trial. We compared the effectiveness of oral slow-release morphine and methadone, and we used a double-blind, double-dummy design, which I'm guiding you over now. The inclusion criteria were basically only opioid-dependent subjects. They were permitted to smoke both nicotine and cannabis. So we did not wanted to have no cannabis on board because it seemed unlikely to get any patients in the study. Then we had a 7-week, then we had a randomization, double-blind, double-dummy. Then we had a crossover in week 7 and transferred them to the opposite medication. What I have to mention, we gave monetary incentives based on the US designs to hopefully to increase the attendance of the patients and to have some reimbursement. This was actually the first double-blind, double-dummy study I did in our university in Vienna, and our IRB predicted the patients never will show up for 14 weeks. And we actually were arguing with the US American publications about this is feasible. So these are the demographic data. Group A and B, first morphine, then methadone, and vice versa. And you see that there was no significant difference between the groups. If we look in our studies now, or we look in WIM studies from heroin, this has been a quite young population in doing this kind of trial, but with a considerable long opioid duration of dependence and heroin use. And this was the retention rate. Here you find the crossover period. Person A had first morphine and then methadone, and the yellow one first methadone and then morphine. This is actually an outcome what nobody likes if you're doing trials to compare different medication. Nobody is happy. So, but this was, I think, but everybody could be happy, especially caring for patients, having such a high retention rate after 14 weeks. So, of course, we had enhanced cognitive behavior therapy for both groups and equal amount of monetary incentives. So, we found in both groups, as expected, a decrease in the injection site with a slight increase again than in the methadone group in the last weeks. Then we looked into all the somatic complaints because we had this anecdotal report and Mitchell wrote that the well-being is better under oral slow-release morphine, and you're going to see a couple of graphs who looks pretty similar. I just point out to this. We have again here the crossover. We find here the morphine, and after switching them to methadone, actually they increased their complaints. A similar picture we find in the Beck depression score. Of course, if you look at the general scores, this is not a highly depressed group because otherwise they would not have been included into the trial. but again, you see that they do better if they were on oral slow-release morphine, having here again methadone and morphine. And it's a similar curve if you look into the state-rate anxiety inventory. So to sum up the results, if we looked into the ratio, we found a ratio of almost 1 to 8. The mean dose of methadone was 85 milligram. The mean dose of oral slow-release morphine was 680 milligram. There was a high retention, a significant reduction in injection sites. No significant difference in the concomitant consumption, actually. Unfortunately, or we found a time effect of increasing cocaine consumption over the 14 weeks. But there was a significant clinical well-being on being on oral slow-release morphine. George Woody published an editorial in Addiction, A New Horizon, Sustained-Release Morphine as Agonistic Treatment. He was very much in favor, said, well, we have to look in a new medication, but we also have to be aware of the diversion issues. There was another confirmative study. This is actually a slide which was provided by Wim. Thank you very much. Andrej Kastelic actually did a study in Slovenia, and he confirmed, on the one hand side, the ratio, his ratio was 1 to 8 between methadone and oral slow-release morphine, and he actually replicated that clinically the population on oral slow-release morphine had a better clinical well-being. Then a recent guideline publication by Anne Linford Hughes and colleagues, they also classified the medication in all different substances, and she also referred that it's used to a high extent in Austria. However, experience showed that slow-release morphine is frequently abused and dominates the black market, which is of course true. But this is not only related to the substance itself, it's also, of course, as we know, related to the prescription habit of physicians. And we have a pretty liberal prescription system. GPs have a kind of minor basic education in addiction in order to prescribe opioid maintenance treatment. But we might discuss, it's always an issue between quality and quantity. So the purpose was to try to have a higher quantity in treatment. We all know this, that buprenorphine was reported to have increased diversion risk and intravenous injection risk. And this is just one of the studies coming out of Australia, I think, yeah. How was it associated with injecting other drugs, buprenorphine maintenance, injection-related health risk, and involvement of crime? Per se, nobody is surprised that if you treat patients with substance misuse, that they might be misusing substances, but nevertheless, from the societal standpoint, we have to be sure to monitor and educate how to apply addiction medicine. This is one of the studies Hannu Alho did in Finland, showing that the street value of a buprenorphine monoproduct is much higher. They pay a mean of 35 euros compared to about 20 euros for the combination product. So, and that's a recent issue coming out of the United States, also reporting that there is observed and diversion risk on the combination product. And if you're more interested in the diversion problem in the European Union, there was a recent issue in Europat's journal investigating, publishing the results of Equator. Equator was a study originally designed in Germany by Heino Stöber, and this questionnaire was retranslated and applied in 10 European member countries and got extended in the last years to Netherlands, Belgium, and Switzerland. And very briefly, the design. This design was, there were treating physicians were interviewed, patients currently in opioid maintenance treatment were interviewed, and opioid users currently not in opioid maintenance. So to get in opposite to the EMCCDA data in Lisbon, who get the reports from the focal points of individual countries, this study actually looked into the face-to-face interviews of physicians and patients. And this is the result. I don't know whether it's really good visible for for people in the audience, this gives you information on Austria and the associated risk of injectable misuse of the medication. You find here the lowest risk was seen in the combination product of buprenorphine naloxone, followed by buprenorphine, followed by methadone, and more than half of the patients of oral slow-release morphine reported injecting their medication, compared with only 17% versus even 7% on the combination product. Of course, everybody who deals with the publication and saw the figures at the beginning, the high coverage of oral slow-release morphine, we of course have to expect a higher misuse and diversion risk. But this is pretty much so. There are several measures needed taken now by our politicians actually to try to reverse that picture. But from a research standpoint, and I was supposed to speak before Miguel, so we look into the antagonistic option of oral slow-release morphine with naloxone, and we are just performing this trial now. And actually, and I want to thank John Strang, who is an advisor of doing this. And I think we have 10 more patients to do. We have a very nice study design. Also, having oral morphine maintained patients with a considerable mean oral maintenance dose of morphine on 600 milligrams, and injecting morphine, and on following days in a blinded way, different concentration of naloxone to look in their clinical reactions. And I think the design seems to work pretty nicely. And at least this is one other option to have a good medication, because seeing the patients who are treated on oral morphine, it's really nicely to see how well they are doing. But of course, seeing the other information of this increased diversion and IV misuse risk, we have to have a safer part of this medication available. And I thank you very much for your attention.